we've got a fantastic panel of folks here that are going to talk about the community supports available. And yeah, so I am Jane. The reason you don't have Pat here and you've got me, I'm Jane Stalabras. I'm the community support service facilitator here at Abbotsford, and we provide community support services for folks in the Glebe, Old Ottawa South, and further south. So, you know, if you have questions and things afterwards, you may be talking to me. Anyway, I'd like to introduce Carolyn, our Peggy. Peggy.
Please tell us your name.
I did. I'm Jane Celebras. And if you want my card, it's out there at the front desk. So, and Peggy is going to be our moderator for today. So,
and Jane, you're our technician, right?
And I'm also your technician.
If you have any issues, you're
I'm in the room.
Okay, perfect. Great. Okay. Now a welcome from.
Why don't we get you in front of the camera? So
Good
people at wine can see.
Good idea.
There we go.
Okay, now a quick welcome from Margaret Tanzer? Yeah, Tanzi. Yeah. Margaret Tanzi from the Seniors Health Innovations Hub. Come on up.
Thank you very much.
Okay, good afternoon, everybody. My name is Margaret Tanzi, and I'm the interim chair of SHE. So what is SHE, you're thinking? SHE is the group, I think, that organized this event today, and it stands for Seniors Health Initiative Hub. So we are a group of just regular citizens who a couple of years ago got together to try and see what we could do from a grassroots perspective to make a difference for older adults living in our communities in central Ottawa. And a survey indicated not too long back that primary care was a big concern for many of our citizens. Either their primary physician had retired or become overwhelmed and left practice. So especially I think in older age, we all need that help to prevent things from getting worse and to keep being well. We also developed an online guide, which we have copies of, for the community, for healthy aging. And we also got a New Horizons grant, so we copied out a lot of these copies. So some of them have been distributed earlier, but it is 2023, but the information is still very helpful.
And excuse me, how do we get this information?
I'm going to leave copies here. Okay, yeah, okay, good question. As today is the home care and community support team from SHE, and we also have a primary care team, and we are working hard to have a nurse practitioner-led clinic for older adults in our community. We've had really good response from a variety of organizations. We met with the Premier's man in Ottawa. His name is Sean Webster. We met with him a couple of weeks ago to present the needs of older adults and this solution that we've come up with in coordination with Pearly Health and Centertown Community Health Center. So really a strong group, a strong proposal, fingers crossed. As well as that, we have a team that's working on new technology with researchers at Carleton, figuring out, are there things that we can have at home that will help us stay at home? So that's the kind of thing they're up to. I may have missed out something. Oh, we have a housing team looking at community housing and communal or cooperative housing in our community as well. So we're busy bees. We welcome all who might be interested in working with us. And today I would like to give special thanks to the group, the team, the community, the home care and community team, led by Carolyn Inch back, Nicole Saunier-Hogue, Deanne Breton, Mary Appleton, Anne Good, and Sheila Tunderham. We will have cards here in case you want to get more information, as well as we have copies of this documents that you might want to see. So thank you very, very much.
Okay, super. My name is Peggy Edwards. I'm going to serve as your moderator, and I'm a consultant on aging. I'm an advocate for healthy aging, and I've been with the Council on Aging for a number of years, and the council's been very supportive of this event as well. Anyways, I want to just very quickly review the agenda so you know what's coming. And I am going to keep us on time. I'm not really good at that, but we've got a big agenda, but lots and lots of great stuff. And yeah, so we want to stay on time. We're going to start with a presentation from our two panelists, a PowerPoint or a presentation, and that'll give us some context for the afternoon. And then we're going to look at some specific scenarios and examples in home and community care. And then we want to hear from you. Okay, so we're going to hold questions till the end of the session. We're finished by 2:30, so hopefully around 2, we'll be able to get to questions and comments from you. And we have an online presence, as you know, so what we will do is people online will put their questions or comments in the chat box. And Diane will be monitoring. Where's that? Diane will be monitoring that. For in the room, it'll just be simply raise your hand, and I'll acknowledge you. You can ask a question or you can give your comment, and then we'll spice it up with some of the comments from online. Does that make sense? Yeah. Okay. Good. And I do hope you'll stay till the end, particularly because hearing from you is going to be at the end of the session, and that's really important. So I'd like to welcome you, and at this point, introduce our speakers, our presenters. Well, you know why they're calling panelists or presenters. Let's just say they do everything. Okay, Amy Boudreau is Carefor's Vice President, People, Strategy, Performance, and Partnerships. In this role, she leads Carefor's People and Culture team, communications and development portfolios, and strategy and innovation initiatives to keep pace with Ontario's rapidly transforming healthcare system. Big job. Amy plays co-lead roles within 2 local Ontario health teams, Ottawa West 4 Rivers, Ontario Health Team, and Ottawa OHT ESO. She is forever advocating for vulnerable people to receive the care and services they prefer and deserve. Amy is also a proud mother to 3 incredibly active, forever fun, and amazingly kind boys. Welcome, Amy. Hey, Kevin. I'm going to pronounce this properly. Kevin Babulic? Yes. Kevin Babulic is the Director of Patient Services at Ontario Health at Home. And he'll talk more about this, but this is the new name for the home and community services that we were used to working with in the past. His portfolio includes accountability for home care service delivery from eastern Ottawa to the Quebec border near Hawkesbury. He has regional responsibilities for long-term care placement, elder mediation, and respite. Kevin is lead for hospital access for all of Ontario East and is on the steering committee for the Archipel Ontario Health Team. He has over 25 years experience in the healthcare sector with direct patient care, research, and varied administrative roles in a broad range of environments. His clinical background is physiotherapy with science degrees from the University of Manitoba and the University of Western Ontario. Welcome, Kevin. And by the way, I'm wearing an ice pack. I had a fall and hurt my arm and shoulder. And I thought, well, should I hide this? And then I thought, no, I'm going to something on home care. And Kevin, you're a physiotherapist. I may just have to hook up with you at the end of the session.
I need a nice peppermint.
Handy things, right? Okay, let's turn it over to Kevin, please, who's going to give us a little slideshow, setting the context.
Dance. Okay, I'm going to try and drive around somebody else's PowerPoint. I just have to get to share screen. Let's see. Oh my gosh, I didn't. Darn.
It's coming on.
I'm just not very patient.
It'll pop up in a second.
Okay.
We will see exactly what you got on the screen. Find this?
I'm looking at something on my screen and not seeing it up there. Good thing we have tech support here.
It's coming.
I gotta say, I do like the venue. Live across the bridge and it feels like the Redbird. This is very nice.
Yeah.
Are you sure? Yeah.
Hey, that's a good place.
It is.
I go there on Tuesday nights for open mic.
Lovely.
There we go.
Oh, there. See, I have to be more patient.
Share screen here.
Okay. It's good. Okay, here I'll race through that slide. Hopefully think, oh, good. Yeah, I'm gonna just.
Please speak into the mic.
I will, as soon as I do the right thing. Sorry about that. Here, I'll lift it up a little. Okay, so who is Ontario Health at Home? It's a new name. It is the same organization. We've been through about 10 names in the last few years, so my apologies for that. There's all good reason behind it, but the new name is Ontario Health at Home. We're the organization that coordinates home care delivery. We work with a lot of organizations, many of which Amy is representing, but we also work with hospital partners where our role is navigating people through the system, trying to arrange services in home, trying to figure out where their next part of their life's journey will be. We work with long-term care, we work with retirement homes, we work with doctors and other healthcare providers. I'm going to race through this. I talk quickly, so I'm from a big family. Just raise your hand if you want me to go slower. Okay, I'll get closer. How about that? There you go.
We can turn the volume up.
No, I think we're good. I'm too far from the mic. Again, I am from a big family. I can be very loud as well. So I'm going to go through just a little bit of information about our organization, who we are, talk about a bit of the services we give. We give in-home services. We work with community providers. We have specialized programs. We also facilitate palliative care in the community, in hospital, and the whole long-term care thing, which I'm not going to get into in depth, but it's a pretty complex process. It's regulated probably, second to nuclear power. We are available to serve everybody in Ontario. So if you have a health card, if you live in Ontario, we are available to serve you. We work in collaboration with other partners who we may system navigate you, saying, okay, yeah, we look after people with really complex needs. We don't do that, but we'll link you with somebody that can. And we're getting more and more connected. I know it doesn't seem like that. I've been in the system. I have loved ones that have been through it, and we'd love to make it more integrated and more patient-centered and more accessible. It's a journey. So yeah, I look forward to hearing everyone's comments at the end. How big is it? We look after almost 1 million people or 500,000 people in Ontario. Our area represents about 10% of that. So it's closer to 60,000 people that are on some kind of home care services throughout Champlain. Champlain goes from Deep River all the way to Hawkesbury. I know Ottawa represents the biggest thing, so you'll hear me use Champlain, but that's just our local region where we go to. So most of what we do is actually the number of visits. I mean, these are provincial numbers. I mean, the provincial numbers, it's quite large. And I don't think people understand that we are actually the biggest healthcare provider in Ontario. So when they think healthcare, they think hospitals, but actually most of it is done in the community, and the volume of people affected is significant. I think everybody in this room fully understands that not everything happens in a hospital. And I think on some of the quizzes, not everybody wants their care delivered in hospital either. Most people would prefer to have someone where they're living in close. So Champlain, here's where we work. We work again in a large area. Eastern Ontario is a little bit different. We have a significant Francophone population. There's a small Indigenous population as well. Who we serve, it says most of our clients are over 65. It's even more than that now. Actually, I think over a quarter of our clients are over 85. So it's not who's thought to be, I'll say, an older population is much more than it was, and that's advancing quickly. Wow, this is some tiny font going on here. I won't go through in deep, but the biggest crux of what we do is helping people transition to other areas. We help people staying home. We want to make sure at those transition points, key ones like hospital, that we can help them transition out and also avoid coming back in. We have our staff in emergencies so that we can actually, when we get referred to and when you're sitting there for 6 hours, if it looks like you're going home, we can try and start your journey there so that indeed we can send a rapid response nurse or do some remote monitoring in hospital. So we also have specialty programs like palliative, so people can die with dignity and in the place they want. When you're on our services, the majority of people achieve that. When you go into hospital, it's almost the reverse. And sometimes it's very well-meaning loved ones, but our focus is on the patient. But again, we're looking after the family at the same time. We do have a service that helps people find a doctor as well. There's not many to find. We can only find the ones that are available, and we focus on the complex group. Sorry if I'm racing through here, but I know my timekeeper is going to be on me soon. To be eligible, pretty straightforward. You need a valid health card. You need to live in Ontario, and you need to require, and we have an assessment. There is no means assessment. That was one of the questions that came through. Everybody in Ontario is eligible. We do make it equitable. Some people with similar needs have no supports. So we need to go look after that person who lives alone with nobody, whereas other people have some other supports, but there is no means testing, and you need to have or a medical condition of some kind. Ours is a functional assessment and it's patient specific. So I'll just keep on going through. Care coordination. This is a word that gets bandied around. We've changed it 6 times over the year as well. This is the person within us, they're regulated health professionals. It's not a protected term. Sometimes care coordinators for other organizations are not. All of ours are nurses, OTs, social workers, physiotherapists in that group of individuals. We do see people in the hospital. They will evaluate needs. They do a standardized assessment that's used in long-term care and complex continuum care in the community. And there's some outputs that will help guide their decision-making. They'll coordinate services and they have an obligation to connect with other services and other providers, because even we do some service coordination ourselves, but more and more it's other people that we're connecting. And I think Amy can speak to that later on when we go through. And we do some of that electronically so that it's a warm handoff. In the past, we used, here's the number. That wasn't enough. We do more now, so we can even help connect you electronically, and more of it is. Touched on this before. Who do we serve? Most of the people we serve are the higher needs groups. They are the people that actually need some physical assistance. It's a little older slide, but 24%, it's more than that, or over 85 now. And we look after the people that have unstable medical conditions, that are frequently in hospital, that need help with personal care for daily activities. We don't watch people shower. Not many people do, but that is an ask. Or watch people sleep. Those are things we can do some remote monitoring and things like that. We look after the people that have some caregiver burnout. We look after the people who are at high risk of institutionalization. We asked a group of seniors, 85 plus, how many wanted to go to long-term care. We didn't have a hand go up in their room. That's not what it is a reality for some people, but it's not what they've done. So our obligation is to try and do as much as we can to support them. It's always good with a story. So yeah, it's an individual called Mary. So she's 85 years old. She lives with her husband who's struggling to meet her needs. We often get into situations where the families have nothing. They didn't even know they have nothing. And I'll say what I'm going to say. Anybody can refer. We do have to do a consent thing. You can refer, your neighbor can refer, your doctor can refer. You don't need a doctor's referral. Then we'll come in, but we will need consent from the individual to proceed. But this Mary, she needs daily assistance with personal care. She needs help with meal prep. She needs help with housework. She's taking medications for multiple conditions. She is finding it difficult to express herself to the point that she's that confused, that even verbal is complex for her. She still wants to stay at home, but she's at really high risk of institutionalization. So I always like a story. It doesn't mean everything's there, but based on the collection, I love it when I get to put that together in a slide deck. Our services, I touched on this before. What do? We're in the community, we're in home. We have a lot of specialized programs, and I'll go through those in a list. Don't worry, there's links all over here and you'll have it afterwards. There's no test. We are in hospital. Long-term care placement is a big piece that we have to do. It is regulated, and we're the sole entity for accessing that. Just some, I know somebody, I know a social worker works at, well, good for you, but there's You can't jump in front of 100 people because you know the social worker. At home, what do we do at home? Care coordination, personal support services. This is the majority of our services. It's when you're familiar with therapies, OT, PT, speech, social work and dietitian services are within there too. Our specialized services, we have palliative care I've mentioned a few times. There's a couple others. They're not big programs, but there's geriatric in the city of Ottawa. Geriatric assessors are run centrally through the Ottawa Hospital. Within outside Ottawa, it's actually us. But we work together, so the same level of services offered to both. The reason I know I'm in Ottawa right now, don't worry. But I know that a lot of family have people that dance in and out, so there's a little bit of a difference. There's also something we do called specialized service, an example, elder mediation. Really complex family situations, we build a safety net that's run by them, and there's some opportunities within there. Somebody comes in to actually mediate within the family. I'm going to keep on racing if I can, because there's a big list of specialized programs, and I won't go through them all. But telehome care, also called remote monitoring, this is really, really growing. So it started with people with congestive heart disease, or people who are dancing into emerge. They didn't need a whole lot of services, but they needed somebody when they needed them. And we've actually even got the equipment supplied. There's hundreds of patients now looked after remote monitoring when they go home from hospital. We started with some of the respiratory ones. We went into COVID and went into some of the other respiratory ones, and then are now looking at the alternate level of care population. We're working in collaboration with the hospitals, the paramedics, and who am I missing? Oh, yeah, and the doctors. But that was a tough one to get on board, was having a doctor calling when we went to the hospitals. And honestly, most people end up not going back to hospital, and we can call up the paramedics who can quickly check on them, notify the care coordinator who will go and see them the next morning. And really, it just, okay, I've got some monitoring, my O2 sats are dropping, and there's tech that we actually supply for them when they go in. I won't go into details on that too much. Palliative care, I've spoke, that's care for the dying. Again, most of our people, it's about 70 to 80%. And this sounds like a funny thing, but they die in their place of choice. So it's all about patient choice, about supporting people. It is a wonderful team with wraparound services, nurse practitioners as well. And they are very incorporated with our care coordinators. Rapid response nurses, these are people when you leave hospital, for those really complex people, they go in and they check on the patient 24 hours or 48 hours after they leave. And they make sure they've got a link with the family doctor, that some of their appointments are set up. They do a quick medication check, and that's huge. With patient's permission, they will even go into the medicine chest and throw out everything from 1962 and keep the most recent things. Oh, sorry, I have aspirins from 1942. I mean, I think they came with my grandmother. There's a cheapness element to me. I totally understand it. We do have a stroke team that works across Champlain, across the whole area. Spoke about elder mediation as well. We also have ABI, that's Acquired Brain Injury Navigator. So somebody that actually helps that subpopulation, because it is a very complex group. And a lot of it is just getting through, okay, that's it. Really, I've got that. You've got an MBA, you could access this. And this individual, there's one in each of 14 areas. So we've only got one, but she does help people go to services available. Lastly, we've got a new thing called an inclusion care coordinator, new, several years old, which looks after some of the vulnerably housed population, because it's tough to give services when you don't have a home. But we do serve people in the mission. We serve people in shelters. So it's a bit there. We go everywhere, and we do link. They help people get an address or keep one. How am I doing for time? I got to race, don't I?
4 minutes.
All right. We do connect people with the community as well. We work with a lot of community support service organizations. And I'm going to list a few. Amy can jump in if I miss stuff. But there's adult day programs. So people, they offer respite to people. They also offer stimulation to some people with infirmities of aging. There's caregiver support groups. And I'm going through a list, and maybe I'm going to forget some, but please, these are all run by a variety of organizations. There's friendly visits. Some people don't need care. They need somebody to visit them, to see them. That exists, again, through the community support services, a bunch of agencies. They have this cool thing called CareDove at the end, which you can actually self-refer, you can jump in. Some have wait lists, some have co-payments, but that's all explained at the time when it comes through. Hospice care is also, not through CSS, it's one we run. We do link people with, and we actually do the application in conjunction with, there's a palliative care network that we're part of. The other things, I mean, as I said, we do, Ontario Health at Home do a lot of personal support services. We don't do a lot of the things that keep you at home. So if you're helping getting care with housekeeping and you know, snow shoveling, so those are the things that are provided through CSS, as well as some meal delivery. We do work with rehabilitation groups, and that's a bit more of the hospital sector. And supportive housing, it's a bit of a minefield to go through as well, but we work with the city, we work with the Ottawa Housing, but as well as ALS for HRS. So assisted living services, we live in acronyms. I apologize, we love them. Assisted living for high-risk seniors is one we actually coordinate access to, even though it's not run by us. And transportation services is huge. Once again, CSS. Amy, I know I lumped everything into one slide, but Anima,
That's our slide.
there we go. Oh, I sorry. Into two slides. I said it twice. The comprehensive support I didn't touch on. So I mean, I did talk a little bit about supportive housing. We work with retirement homes. These are a huge and growing sector. We give services, about a third of our services that we give in home is actually in retirement homes. We don't double up what's already given, but just because you choose to live there, that's considered your home, we will give services there. In assisted living, when it's funded by the government, we're not necessarily in there, they're looking after you. But there are other programs, again, we work with them. So short stay respite and long-term care, people can go up to 90 days a year. They can live at home, but pop into long-term care so that their loved ones can continue to support them in home for up to 90 days in a year. It's on 2-week intervals where we can help with those things too. Long-term care I kept to the end because this is when all community options have been exhausted. Long-term care is an important piece of the puzzle, but often people want to jump there a little bit early, and that's not in fact what patients want necessarily. For people that are appropriate, it's great, but these are people that require 24-hour nursing and personal care. Even if that's where somebody may end up, we very much encourage them live their best lives on the way there. I mean, it's part of the journey, but it shouldn't be. When we ask older seniors if that's where they wanted to go, they didn't. But totally, if they had to, they would definitely make that decision. Palliative care, I think I talked about this a little bit, so I'm not going to talk about it in depth. In hospital, and one of our cases about this, we have care coordinators in hospital. They're in all hospitals, big hospitals, they're in more. They're in the big hospitals, they're in Emerge. They will assess your care needs, they will set up services, and they'll arrange for somebody else to see you at home. They will look after the services. So if you're there, I mean, there are cases sometimes, oh no, you'll be home, you'll be fine. And we get referred to after the person goes home. Not ideal. We prefer to set up services before they leave, but we are working with our hospital partners to try and tighten up as much. And we do have a bit of a directive right now from the ministry saying, you guys got to work together better. So that'll hopefully improve things. I was going to explain really quickly, and this is where I'm going to race through, but long-term care, it's when living at home is no longer possible. There's a bunch of stages through it, and I think I'll just go through those. So we do a functional assessment. There's a capacity assessment. We involve the MD. There's a lot of choices for when you go into that, but it's a long thing. Your care coordinator will walk you through that, and I'm skipping through this, I know, because I'm at 1 minute, I think. There is a co-payment in long-term care. I want to make everybody, it's a provincially regulated rate. There are a few choices. It depends. There's a base rate that gives you the base services. The rest is just about a nicer room. So that's the big difference on it. So how do you call us? Anywhere in the province, skip the first part, 310 42s.
And what is the wait list for the long-term care in the Champlain region?
Oh, wait list is about 6,000 people. And that's for about 7,600 beds. And it's changed a little, but I'm sorry. I know those numbers like that, so no, we can get more depth in that later on. We have somebody there, we're a 712 organization, so anybody can call, you can fax in, there's a toll-free number, but it's on here as well. And there's a few links that you can do. I wanted to let people know that the resources, Champlain Healthline, it's not the best search engine, but it's got a whole lot. I generally go through Google, it points to Champlain Healthline, going that way. Again, Ontario Health at Home, everybody it's on there. You can look at the links. Sorry if I'm going too long on how to get us, but there's a quick piece. Oh, I can give all that information to everybody at the end with all the contact information. The 1-800 there, I'll leave it up as I leave the microphone.
138. Thank you, Kevin. Fabulous. Just a quick question for Amy. Did you want to add anything there, particularly from where you work and the organizations you work with?
Yes, I just wanted to give you a little bit of just an overview of who Carefor is. I think many of you have seen our vehicles driving around the community.
We'll just stop sharing the slides.
Oh, yes, okay, stop share.
Yeah, perfect.
A very close headshot. 4 people on the line here. Anyway, Carefor is an organization over 127 years old. So many of you will remember it as being the VON, so Victorian Order of Nurses in our community. So we are 3 different branches now in one under a new name called Carefor. So again, many of you will recall VON services. We actually deliver services right across the Champlain region, which is what Kevin was referring to, and you saw the lovely image of that up on the screen. We deliver home and clinical care services, so we are absolutely in many people's homes delivering nursing services, allied health services, which, as Kevin alluded to, were PT services, physiotherapy, occupational therapy, dietetics, social work, and we also deliver many personal support workers services or personal support services with personal support workers all across the city. We also have a nursing clinic in the community on Belfast. Some of you may have been there or may have driven parents there from time to time. And that's where we deliver in-clinic nursing services. So many folks who come out of hospital, need some further support, will come into the nursing clinic to receive those services and then just go home. And we do promote that because it allows people to also improve mobility, to be able to leave the home, get those services and go back home. So it improves the whole holistic view of one's recovery. We also have what we call CSS services. Heard a lot about those today. We are the biggest provider in the region of community support services. So it's all the list that Kevin shared, those services in the community that are vital to keeping people at home and to keep people in a place where they prefer to be. So those are very proactive services. They're very much focused on illness prevention, health promotion. And so we really do recommend those services to people early on in their journeys of frailty so that they can really take advantage of those community services that allow one to maintain their holistic health in living in their community. We also have retirement homes in Pembroke, not really relevant to you folks, and have a hospice. But one of the things I wanted to mention in terms of the palliative care element is we are one of 3 providers in this region who deliver in-home palliative care services. So we have a bit of expertise in that area, but allowing our nurses to go in home and support with palliative care and also support with MAID services as people so choose to have to follow through that route. And that's a little bit about Carefor. We are a not-for-profit charity, as we always have been. And so we are ultimately, our mission is to provide high quality services to people who need it to help them stay home. Thank you.
These are fantastic presenters and healthcare workers. I know you probably have a zillion questions. We'll hold the questions till the end, and I'm sure you'll be able to connect with both Amy and Kevin, out of here and get some more answers that you might need. As Kevin said, sometimes it's better to look at a story than a bunch of statistics. And the planning committee that put this day together had the great idea of coming up with some scenarios or stories, and then having Amy and Kevin react to some questions about those scenarios. You've probably experienced them. So I'm going to start with the first one, scenario 1, and it goes like this. A couple in their late 80s is hit while driving their car to church. The husband is just shaken up, but his wife has a fractured sternum. After running tests, the hospital emergency department discharges them to their home, even though the woman is still in pain and won't be able to take care of herself. So, question number 1, what services are available to support this older couple as they are discharged from hospital with a plan to return home with an appropriate care and support plan for a successful recovery. Look at this.
If you're closer, then we'll hear you on Zoom as well. So,
So would you like me to go over there?
well, if you kind of do a huddle around. Doesn't matter, could not do that. Okay. For our remote folks, we have more than, we have many.
You can run it,
Almost as many out there as in years.
Well, we'll turn this one off.
Oh, you're just gonna use this one?
Yeah, we'll leave.
Yeah, that should be fine. Go ahead.
Okay, I'll start with, this is a couple in Emerge, just so we do have actually care coordinators in both in Emerge. So if indeed we're notified, we do try to do and pull patients before, but a couple like this may actually, if they're on service already, we'd get electronic notification so that our care coordinator in Emerge would be able to start them on their journey. If they're not within services, we'd work with the team to do it. In Emerge, they also have somebody in the hospital, in all hospitals, except for a couple tiny ones, what's called a gen nurse, the geriatric nurse in Emerge, who will go and see the couple as well. And we work in collaboration with that person. So even before they go home, we could do things. We can set them up for some remote monitoring if needed. But part of the tough problem is people can sit in Emerge for 9 hours and we're not notified yet. So we are working more to try and maximize some of that and indeed get in to see them before. If we don't, we often get referrals and a care coordinator will see them at home. They will do a patient-specific assessment to their needs to determine what their needs are. Many of their needs, this is a couple that was in a car accident. I just wanted to put the little twist in here because it was a really interesting scenario. I said home care services are available to everybody. They are. But in the case of MVA, Ontario has some legislation where it makes the insurer responsible for the PSW services at home. So for that group, they would actually we might assess them, but if they have professional support for physio, OT and stuff like that, we would go in and support them. But for PSW, in this really exceptional case, I was like, did they know that when you guys asked the question? Okay, so good on you. But indeed, we would do that. There is also some programs that are available through CSS. And again, those are the ones I'm talking about, services to support needs and a lot of clinical needs. But the ones that keep you at home, actually, I'll turn it over to Amy to speak to some of the CSS services.
Yeah, absolutely. So in that case, when people return home, we really want to, and starting in the hospital, we do have folks who can support to line up the couple with community support services. So obviously this couple has been through a traumatic event, they get home, they will qualify for services that would support to prepare for meals, to have even transportation if needed to be home, to get home, homemaking services. They definitely have access to those types of services that would allow them to get on their feet and to be home and support with those daily activities of living to get them back on their feet. But then, there might be other services in the community as well that we can wrap around them to allow them to improve mobility when we get home. And obviously we would, as Kevin alluded, we would provide those physiotherapy, occupational therapy services through Ontario Health at Home. But there may be some other community services that could support with movement and things like that.
Amy, I'm just gonna put one little adjunct because as you were speaking, it occurred to me. Okay, well, when does Amy's organization go in, and when do we go in? So I just wanted to clarify one thing. So Ontario Health at Home, where the people go and assess to need. Amy's organization sits in, I'll say, in two groups. Yeah. So we have service providers that we actually would fund to services we order. So Carefor is one of our biggest service providers, and we would send out a note. It's an electronic offer. They have like half an hour to get back. Can you help this patient? And we go to the next one. So that's why it's set up like that. But Carefor is one of many service providers that we actually use. It's called a brokered service arrangement, but you'll have a care coordinator consistently decide so everybody gets equitable allocation of services. But indeed, it may be a different service provider. So Carefor sits in that group. Plus, they also sit in the community support services. So just to put that in that, in case it's confusing for who goes to who, that's indeed how it works. And with this couple, I want to mention, because they're older, as a veteran for support, if that person happens to have some military service, we also work with Veterans Affairs Canada to try and get some of those supports.
stay here. Yeah. Okay, terrific answers. Now, this scenario is going to develop a little bit more. A change in situation. So following the discharge from hospital, the family realizes that dad is less cogent than they thought. He can't take over household duties or care for his wife in her current condition, and now it is obvious that he should stop driving. So, a couple of questions here. Given this change in needs, what supports are available to the family for cognitive assessment, possible cognitive diagnosis, and driving assessment? If eligible, what types of support are available and how much would it cost?
Going up and down. I love this question again, because it's one it's a difficult question. I'm going to start with just one statement. Everybody is competent until such time as they're deemed non-competent. So this is a very tough one for families. I would not recommend the first stage is, oh, better go for a capacity assessment. That will get the individuals back up, and understandably, because you're taking away a big piece of it. That we would refer, if you're concerned, it would be going through the MD. Every MD from a driving perspective has an obligation if the person's unfit to drive to take that in, to take that away. But often that's not the starting point for some of the families just been made aware. It may be obvious to them that they have concerns, but then that would be a discussion within the family. There are some options to go through, but you don't want to sever this very important connection at the point. So family doctor, an appointment with the family doctor, being said, Dad, we have some concerns about this, and having that open discussion with it, because there are memory clinics which can assist. So we would help you guide you towards Briere, to Jerry Rehab, to some of these other things. There's a driving clinic if they get there at the rehab center as well, where they will have somebody do that formal assessment. I wouldn't suggest that's the starting place. The starting place is an open discussion, and it's about concern, and it's concern for the individual, because there is a capacity assessment that you can end up down that road at the very end. If you think somebody's truly incapable, it does have significant costs with a capacity assessor. Most people, the vast majority do not need to go through that. I can even give a personal example. I mean, with my dad, I just want the car there just in case. We convinced him to gift it to his grandson, and it was done. No more car, it was easy. But we did talk about concerns. So I think that open dialogue is a really important piece. And I think Amy can talk a little bit again about the supports in community. If we will do an assessment on dad, if perhaps, but again, the bar for us would be if there's some needs, then we would order those services. We may go through, we have some that we provide ourselves, so maybe some other services we can get. But Amy, I'm going to toss it back over to you on that.
Yeah, that's great. So yeah, we at Carefor actually we run two regional programs that are really CSS services. So one of them is the Regional Non-Urgent Patient Transportation Collaborative. So it's a regional approach to providing transportation to those who need it in the community, for people who need to go back and forth in hospital appointments, maybe even grocery shopping. So we coordinate that care for the region, or the services for the region. So certainly transportation is a big one that many people rely on if they no longer drive, and if they're dependent on others to take them places, because your family members are not always available to do that. So that's a service that we deliver, and we work with 26 partner agencies across the region to deliver those services. So we're the coordinator, but we also partner with those organizations, and there are other like CSS agencies, like Carefor, who actually deliver those services each and every day. We also have what we call we also coordinate the Going Home program, which is a different program, but it's supportive of people who are transitioning from hospital, and supports which include transportation, meal delivery, basic home making, personal support services. So we are also the regional coordinator of that type of program. But in addition to all of that, we also have a variety of other services, which you saw on the list above, and some of them include adult day programs, specifically designed for people who are living with beginning to mid stages of dementia, who can it's also a form of respite care for caregivers who can, take advantage of those wonderful services to engage those folks in those particular programs. We also have over a 24-hour respite service that we provide in the community at the Pearly. So in partnership with the Pearly, we do deliver round-the-clock services for caregivers who need respite for loved ones that they're caring for at home. So there's a variety of different services that you may not even know about that are available. And then certainly, you can find when you search online, or, certainly Ontario Health at Home is great to connect people to those services in the community. But as you will see, there is a whole network of CSF agencies that work across the city and across the region. And so the goal is to, in most cases, is to try to find services close to your home and to have that as close to your neighborhood as possible.
Okay, there was one more question related to this scenario, but in the interest of time, I'm going to skip it and move to the next scenario. But let me tell you what the question was. After the wife heals, she will be taking care of her mentally declining husband. Will she be eligible for respite care? And Amy did speak to that. And what options might she have in the community and support services at subsidized costs might she be eligible for? So it's the whole area of the caregiver. We have the patient, we have the person in great need, but what about the caregiver? How can he or she get support? So maybe we'll be able to talk about that a little later. Okay, next scenario. A 92-year-old woman is cogent, healthy for her age, but living alone in her own condo. Some of her friends have moved to retirement or assisted living residences and regret their decision. Lately, she has noticed that she is not interested in preparing meals, and she worries about getting into the shower alone, as her balance is not good. This is kind of sounding like me. She wants to stay where she is. How can she get some support at home to age in place?
Do you want to go first, or do I want to go first? We'll keep the method going. So, as I mentioned before, and I'll be quick on this, Ontario Health at Home, anybody can refer. She can refer herself, a neighbor can refer, doctor can refer. We will have to do a consent check with the individual if they actually want. We have some people that, they need it. I'm not interested right now. We'll try and say, we can come and do that. So anybody can refer. Following that, we'll do a specialized functional assessment that will determine needs. I mean, for this lady, she may not need any personal support, worker support. She may need maybe getting into the shower. She may need an OT going to see her and do a home evaluation, recommend some steps. So she can maintain her independence. As things advance, we will, if she's on service, we will do a regular check. I mean, depending on the patient, how they present to us, sometimes we do it really often. Some people we just go in and check, others will do a call, but we will do a regular check. But this is when, again, we work with our partner agencies and community support services. So even if the person, she sounds really highly functional right now, some concerns, we can go in, we can investigate, and we can refer to some of the services Amy mentioned before. And I could talk maybe, should she progress, about some of the things open, but Amy, maybe you want to jump in.
Yeah, just recognizing that, this is the perfect case scenario for community support services, right? Someone that we really want to be able to live at home, who really wants to be able to live at home and stay there, but yet needs some supports. And so through that assessment, not only of herself, but her home, we determine what those needs are. And then of course we would develop a care plan that would best meet her needs, ideally with her, informing that based upon her needs and preferences. So again, we would, assess those needs. We would then determine what reasonable support she would need from a personal support worker, from a homemaking perspective, from a meals delivery perspective, from someone to, assist with maybe putting some equipment in the home to help her to be able to, still live independently. But there is a myriad of services in the community that we can engage for her. Friendly visiting, as Kevin mentioned before, You know, we certainly have other services where we bring people together. There are certainly, you know, like down the hall here where when we first walked in, we saw that there was an exercise class happening. There's a lot of different types of community support services that are available. But again, I think we even have over 40 in our organization, 40 different types of community support services. So there's no end to the support. It's just a matter of determining what makes sense. And so I say there's no, you know, cookie cutter approach here. We really do have to assess the needs on an individual basis and then try to align the services that best meet those needs. And then for us in the community, reach out to deliver those services. What I would also say is that we really do want to encourage people who drop in and visit this woman on a regular basis to keep their eyes on her, right? So it's a community of caring, really, and to keep eyes on, and it's people that she sees every day that are also going to recognize when things change. And so it's, you know, in many ways at the OHT level, we often talk about, you know, building more awareness in the community of how they can support their neighbors, their loved ones, to be able to access those services when things do change, because they're often the first people to see those changes. So even though, you know, our care coordinators repeat assessments on an annual basis, that's not enough, right? We know that things change all the time. So it's trying to educate the community to say, okay, when we notice these things, it's important to reach out and to notify folks that, you know, people like on their at home, there's been some significant change in the home, and that we need to reassess where people are at.
And if I could just add on, so there was a question, and as this woman's frailty may increase with advancing years or other pathologies that may present, we can reassess. So even if at one point we've gone in and it's early and we've referred to CSS, often our CSS providers will send a re-referral. Anybody can refer, and you can do it again. Oh, it's only been 3 months that you saw them. Yeah, we'd like to come in. Would that be okay? Oh, sure. I'm the same. And then we walk in and there's some significant changes. So we can certainly reevaluate and can reassess if they actually need some hands-on care or some professional services to help meet their needs and their goal of staying at home, and help transition them, even if it wasn't their first choice, to another living arrangement, should that be appropriate.
Anything else?
I think that's, yeah, I think that's it.
Is the gentleman that left these questions here? Yes, okay. We'll try to get to some of them. Thank you. He's lost his voice, so he wrote them out. Great. And it is time to move to questions and comments from you, both in the room and online on the Zoom. But, you know, my doctor said when I hurt my shoulder and arm, she said, don't sit too long. You don't rest it. You got to keep moving it. So I just invite you to stand up if you feel like it. Yes. Say hi to your neighbor. Twist a bit. Move your arms a bit. I got to move my shoulders. Okay, great. Let's sit down.
Thanks, Peggy.
Okay. Oh, there's somebody really doing some good stretches. Nice work. Okay, hands up in the room to start.